Thank you very much, and thanks for inviting me to be part of this event today. Very happy to be with all of you. Indeed, I'm going to reflect a bit on the gap that I perceive to exist between research and policy in global health. I have a lot of very techie slides, I apologize. But I was told by the organizers with this audience I could be a bit provocative, so I'm not going to give like a nuanced overview of a research agenda, but I'm going to reflect on my personal experience moving from academia to the World Bank, a move that I made now 8 years ago, and reflect a bit on sort of the disconnect that I tend to see between some of the research I personally was also doing and what I saw were the policy questions on the ground with the governments that I started working on. So two caveats to my talk is one, I left academia 8 years ago. Perhaps some of my observations are dated. And second is that I'm a health economist, so I'm really reflecting on the field of economics within global health, which might be a bit specific. So, as I said, I left academia 8 years ago. I started my career not very far from here in Erasmus University in Rotterdam. I did my PhD. I did a postdoc, and then I worked hard to get a tenured position as an associate professor, which I did, and then I left quite abruptly. In retrospect, that was perhaps a bit of an early midlife crisis, but to a large extent, it was also driven by growing frustration that I had. I felt that a lot of the things that I liked working on, this policy dialogue, capacity building, were secondary to what I had to do to make a career in academia, which was publishing. And in economics, at that time, very much publishing in a fairly narrow set of journals with high impact and focusing on methods and establishing causality, using panel household survey data and applying econometric techniques to establish causal relationships. That sort of increasingly frustrated me a bit, and admittedly, fairly randomly, I applied for a job at the World Bank. I got that and sort of been there now for 8 years. I've been enjoying that quite a lot. I've worked mostly on sub-Saharan Africa, so my talk really reflects that experience. I've been based in Senegal for a couple of years in Dakar, and now recently moved to Morocco and working on the Middle East portfolio. So let me share with you my experience. So my research while I was in academia was very much looking at the question of how can we increase access to quality and affordable care for the most vulnerable and poorest populations in low and low-middle income countries? And as economists, we like to look at the role financial incentives play within those questions. So two questions I studied a lot were, does pay-for-performance work in terms of increasing access to quality care in very resource-poor settings? And second, does health insurance work in increasing access? So let's start with that first question. Can we pay providers better or more for delivering quality care to the most vulnerable in, again, low, middle income countries? This question has dominated a lot of the sort of global health economics literature in recent years. There's a bulk of research on this. I'll summarize it in 3 minutes. So again, it's not a very nuanced picture, but let me just tell you what I think happened from my perspective. So recognizing very stagnant trends in service coverage, poor health outcomes in many countries, lack of progress towards the MDGs, and also combined with enthusiasm that a few donors had. In this case, I think it was the UK and Norway that started this movement, of some early evidence on performance-based financing coming from Burundi and Rwanda. It triggered some donors, bilateral donors mostly, but also the Gates Foundation, to come together and pool resources in the bank in a multi-donor trust fund and to support the implementation of performance-based financing schemes in almost 30 countries, all in low middle income countries, the majority in sub-Saharan Africa. Interestingly, they also put aside quite a lot of money for a research agenda, impact evaluation portfolio around all of these schemes. And this is fairly exceptional, right? That you have the implementation of so many similar interventions in the same time frame across so many countries with an impact evaluation around that. So that generated a lot of evidence on the topic of performance-based financing. Now, I recognize we have a diverse audience, so let me explain to you what I mean when I say these performance-based financing schemes, using an example of, in this case, Nigeria. So what happened? In Nigeria, a selected set of districts were chosen. Within these districts, the health centers received additional financial resources. These resources were in proportion to the quantity and the quality, the performance of the services they were delivering. So you have to really imagine a checklist, right? There was a list with a number of antenatal visits, deliveries of vaccinated children, a price for each of these, and every month verification teams would come in, do the multiplication, calculate the performance budget, give that to these facilities. Interestingly, facilities had autonomy. They could use this money quite flexibly. They could pay bonuses to their staff, they could upgrade the infrastructure, they could procure medicine, whatever they felt was needed to increase their performance. These were compared to a set of control districts where nothing happened. It was business as usual, input-based government financing. And interestingly, there was a third arm where they implemented what was called direct facility financing. This meant that facilities in this third group also got additional financial resources, also got the autonomy to spend those, but the amount of resources was not tied to their performance so closely. They didn't come with this checklist, right? They just gave them lump sum budgets. Now, you can already understand the idea of this design is to tease out not only the impact of giving additional flexible money to facilities, but also to tease out the impact of this pay-for-performance mechanism, right? So what's happened? Let's look at the results. These are two outcome indicators. The title is gone from the second one. Anyway, the first one is the proportion of children that are fully vaccinated. The lower graph shows you the proportion of births that occurred in a facility, institutionalized delivery. The light part of the bars show baseline data. The black bars show endline data, right? Take the upper graph. The first two bars show you the increase in the project areas. This means both the PBF and the DFF combined. Both facilities where additional money was given, right? If you look across these two outcome indicators, you see a big jump, right? You see an increase in vaccination rates from 30 to 45, 15 percentage points. That's really a lot, especially if you consider Nigeria stagnating trends of service coverage for quite many years. And you see something similar, even bigger, for institutionalized deliveries. You see very little happening in the control areas, right? So you can sort of assume this increase is really driven by the fact of by the interventions. If you compare the DFF and the PFF, this tends to vary. In some cases, you see for vaccination, the direct facility financing performs better. For deliveries, it is the performance-based financing that delivers better. There's a lot of variation with that. Now, you have to imagine this kind of impact evaluation was replicated across more than a dozen of countries, and the evidence is still being accumulated, actually, as I speak. So we tried to recently summarize all of this evidence in a book that's available on our website. But in short, I think for me, the key conclusions from this is that, yes, in all of these schemes, giving additional resources to facilities seemed like a good idea because we got quite significant increases. And honestly, if you think about this now in retrospect, it's not surprising. No? These are very poor settings in poor countries where obviously financial means are a bottleneck. So giving additional resources does have an impact, yes. But okay, more interestingly perhaps, is the fact that on the whole we get very similar results across the performance-based and the direct facility interventions, meaning that we don't need this close link between performance and payment. And that's very good news because that makes the intervention a whole lot cheaper. Because as you can imagine, the performance-based arm is much more costly to implement. You need to send these teams to verify all the time and then counter-verify. Now, okay, if this is good news, why is this not happening? Why do the majority of these schemes have now stopped to exist when the project money, the World Bank money dried up, basically? And why have so few of these schemes been integrated in the government system, despite all of this rigorous evidence? Well, to understand that, I think you need to think a bit about what health financing in a country like Nigeria looks like more generally. Right? We're talking about a country where the total health expenditure per capita is $85 US, give or take. $11 is spent by the government, so around a bit more than 10%. The figure here shows the composition of health spending in Nigeria and the trend in the last 20 years. You see the bulk is this red bar, right? The red bar is out-of-pocket payments. Basically, the health system is dependent on people paying out-of-pocket when they're sick and they show up at the hospital. The green part is not negligible. My colleague spoke about that already, is the external financing. And then the blue part is government spending. So we're talking about $11 per capita that the government spends on health. The PBF schemes I just talked about cost around $3.50 per capita. So, we're talking about a 30% increase that we, meaning with the donor community, we provided. So that's very hard, of course, to institutionalize just from a fiscal space point of view. But not only that, also this very little money that the government has to spend on health, the large majority of that is fixed in salaries. Around 80% is fixed in salaries. Those are civil servants that are on the payroll usually for life. You can't hire or fire that very easily. So it means of that $11, much, much less can be spent in a flexible way on these kinds of schemes. But also that little money is tied in a very rigid system that is very input-based with very rigid public financial management procedures. A government cannot easily pay performance to health workers, right? Because you would have to exempt them from the civil servant law and create a new law governing them. Like, this is a process that could take 5 to 10 years. So in retrospect, when you think about what we did with all of these pilots, we designed this very innovative scheme, fairly generously financed, in a way that's almost orthogonal to how a government system works, where you have rigidities, you have ex-ante controls, not ex-post, where you have public financial management rules that are very rigid, where facilities don't have bank accounts, they're not allowed to receive financial resources, they allow inputs, right? So it's not a big surprise that perhaps this rigorous evidence didn't really change the situation and hasn't been really taken to scale in many of these countries. So the actual questions that I feel I'm often asked now, working with a lot of these governments quite closely, is, okay, how do we move to more output-based financing, and how do we focus on the results within our system? How do we strengthen our management information system, which is often still paper-based, right? How do we make that digital so we can actually see what happens where and we get a better sense of performance? Do we even want fiscal decentralization? Do we want our health facilities to have bank accounts? And if so, do we then train doctors to manage resources? Or do we send accountants there to help them do this? Right? All these sort of questions that are in relation to implementation, incremental implementation, about what is feasible within their system. And those, of course, you can't answer with an RCT kind of design or with causal inference. And perhaps, admittedly, they're also not so interesting from an academic or purely intellectual perspective, right? So they tend to be very, very under-resourced. A second question that I'd like to use as an example is this question of, does health insurance work? Again, a question that's been very prominent in global health economics research, to which I also contributed. Health insurance is more difficult to sort of randomize and pilot, so you have a lot of studies that compare the rollout of health insurance across countries, or use the staggered implementation within a country, or compare across population groups. And they all look at this question of, does health insurance, so people having a health insurance card, does that increase their access to quality and affordable care? Again, in very resource-poor settings, looking at the most vulnerable population groups. And they often find, no, this doesn't really help, and we don't see a lot of great impact. So that leads then to these papers being published advising against health insurance, even some authors calling it addiction to a bad idea, social health insurance being this addiction to a bad idea, and we should stop supporting that. And again, having worked now with policymakers a lot, I don't think this is the right question or the relevant question to ask. And the reason for that is, if you take a step back and we think about what health insurance really is, right? Health insurance typically means that you, as a government, that you're going to mobilize resources. You're going to try and find money from insurance contributions, some from taxes. You create a pool of resources. You're going to identify a target population for whom you're going to promise a benefit package, a set of services that are cost-effective and in line with the disease burden. And then you're going to use that pool of money to strategically reimburse providers and compensate them for providing these services to those who are insured. Right? That's in a simplistic way what health insurance is about. Now, if you remember the beginning of my talk, the second part is very difficult. Strategically paying providers in these very rigid public financial management systems is very hard. So what countries then end up doing is they create an insurance agency. They try to escape some of these rigidities, and they set up a health insurance agency that is in charge of this relationship between the purchaser and the provider. I'm sorry, I know this gets a bit technical and perhaps a bit boring, but it's just to make the point that this is a huge and complex undertaking, right? And there's a lot of things that can go wrong in this process. It's also not something that governments do overnight. It's not a 0-1. It's not something you just implement. Many countries have been doing health insurance for 10, 15 years, right? Typically limited to the formal sector because it's easier. You can tax their wages, you can raise contributions from their salaries, and you can better manage the scheme. So the question that they currently have is, okay, how do we move to universal health coverage now, using perhaps this insurance scheme we already have as an entry point? Could we expand that to cover the full population? In many low, middle income countries, the poorer population groups are sort of entitled to free public care, right? Which is often not available and often not free because of inadequate financing. So the questions really on the ground are, okay, how do we do this? How do we raise money now to cover the insurance premia of the poor who are unlikely to be willing or able to pay? How do we bring them in this insurance scheme, make sure they really have access to these services and that we really can reimburse providers for providing these services? How are we going to raise money from that big informal sector who is perhaps more able but also not likely to pay insurance contributions? And then third, how are we going to manage and implement the insurance function? How are we going to keep these providers on a budget? How are we going to monitor quality, enforce that they don't over-provide, make sure they respect patient pathways? How do we strengthen that capacity, which is often really lacking in many of these countries and is even very hard to do? You know, in the Netherlands, Belgium, this is a really difficult task, and you get into political discussions all the time. So again, my point is that the questions that are really sort of on policymakers' minds are those. How do we move forward? What is feasible? What can we do within a political context? And the sort of does something work 0-1 is really not very relevant anymore at this stage. So let me conclude then by saying that I think, at least from where I sit and where I used to sit, that academic research in economics is much too often looking at whether something works or not. And that something is often also really not aligned to the economic and the political reality of many of the countries that it is being piloted and implemented. I think policymakers really want to understand why something isn't working, how it can work better, what the sequencing should be of incremental change, and what they could actually do in the short, middle, and long term. And that these kind of implementation questions are often not sort of lending themselves to very rigorous causal inference, and or perhaps, as I said before, less academically interesting, and that creates really a disconnect. And if I'm thinking about why this is the case and why that's happening, and now I get a bit into the topic the previous speaker was already talking about. Now I'm speculating because I'm not in the research field anymore, so I'm not sure, but I think there's 3 things we should really keep in mind. And the first question I think we should ask ourselves is, how do we value economic research in global health? Are there other metrics than publishing in high-impact journals? How do we really value the impact certain research has had on the ground? And second, that already was mentioned, but who has the resources and therefore the power over defining the research agenda? Where does that lie? That doesn't lie with the policymakers, at least that I work with a lot. They really have very little access or say over how research budgets are being spent. And I think that's something that really should change and that we could all play a role in pushing for. And then third is, how do we really strengthen seriously research capacity in low and low-middle income countries? I find this very frustrating, and perhaps the biggest bottleneck to real health system strengthening in the countries that I've worked in is that you don't have often a critical mass of research capacity, think tanks, universities, who are able and have the resources to reflect on a continuous basis about the functioning of the health system. And here I'm also wondering how and who we can fund this better, because typically the big donors in global health, they raise their resources on an agenda, right, on certain diseases, certain priorities, and they also need to show to their constituencies. That can be bilateral donor like the Netherlands, who needs to argue to the population, or even in the bank. You know, we also need to raise money every year. You need to show results in a fairly short window. 5 years, you need to show how many lives you saved, how many people have benefited from certain interventions. But if you really want to strengthen capacity, research capacity, there won't be results in 5 years. That's a very long-term agenda. So you're in it for the long haul, and you need to be willing to take risk, because that result won't materialize in every country you invest in. So these are open questions that I don't have answers to, but that I wanted to put on the table. To conclude, if I can just say, when I was making this talk, I thought it's interesting, as health economists, we like to study the role of incentives, how incentives can steer appropriate care. And then we don't often talk about how incentives actually steer the appropriate research agenda. So I'd like to just leave that question with you. Thank you.
Thank you. Thank you very much. Is the pay for performance not exactly the same example where funders are pushing their agenda and then governments are basically shown it works and they can't apply it? It is?
Well, that's the case I was making, right?
Yeah.
That we
is there a solution for that? Because one of the things that maybe there was a meeting on performance-based financing, and the conclusion was the only way to change that is have governments involved from the beginning in these kind of systems and not having it paid by outside funders, because that's an interesting pilot project, but it won't work in the end. Would that help?
Yeah, I mean, like I said in the beginning, I'm not giving a very nuanced talk. Yeah? I think there has been a lot of value of all of this work, obviously, because it is true that many countries, while they haven't taken up these type of schemes, it has led to a shift in the mindset, right? And they're now looking at how do we do this within our system. But I think, yes, the process could be much shorter if you sit very closely with the government and try to design something that's feasible within their system, something that at least within 5 years could be to some extent taken over by a government budget. Yeah.
Okay. Questions? Are there other health economists? Different. There you are. Well, you have to.
Or not.
Okay.
So, thanks, Ellen. Yes. So, well, to me, at least, as a health economist, this is indeed very provocative, and I completely recognize what you're talking about when you describe how academic research in economics is driven towards these very narrow set of questions, right? At the same time, I think, so you talk a lot with governments, so you hear a lot about the questions that they have, you list them. You're also at the World Bank, and the World Bank is a powerful player in itself. So to what could you see the role of the World Bank in changing these dynamics and perhaps also funding different types of research and promoting different types of publications in this?
So I was expecting this question. I thought about that. And I want to clarify, it's also a misunderstanding I had when I joined. The bank is a bank, right? There's a lot of money, but we use that money to lend to recipient countries. That is, we're not a funder of research, very small. We don't have that kind of resources. The majority of the resources go directly onto a government budget for loans. So it's not as if the bank is a big funder of research and makes those decisions. Having said that, I do think there could be a role exactly for the bank to help convene some of the key donors and create more flexible financing at the country level for research, and to have ministers with their departments set the agenda and have full access to those finances. So this is my personal view. I'm not making here any. So I do think there's a role we could play, yes, but the bank doesn't set any research agenda. And also, the bank lends, but we lend to a government program and government priorities. And of course, in that discussion, there is give and take, but we don't implement projects as compared to many bilateral donors who would go and implement. We really just lend to a Ministry of Finance. That's an important division.
Okay. There was another question. Yes, please. Oh, two. Yes, you go ahead.
I've often found that funders have agendas which are vertical, right? HIV, tuberculosis, malaria, etc., etc. Yeah. Whereas actually the World Bank and the ADB, etc., are more open to at least discussing more infrastructural, cross-disease topics, probably because the decision of where it has to get invested is in discussion with the government.
Yeah.
It feels very inefficient to have a community screening program or set up for a disease where the population is the same, the community worker, especially with digital tools, you can actually make them do much more than a single disease. Is this a dialogue that is happening between the World Bank and the ADB and the funders on how to steer it, how to steer funding, if not totally, at least partly, to non-disease but more horizontal?
Yeah. No, thanks. I'm happy you brought this up. I was thinking this in response to my previous colleague's talk. I think a big perverse issue in global health funding these days is exactly that, is the fragmentalization of financing for specific diseases and specific topics. And the problem is that all of us, the bank, Global Fund, Gavi, we are all raising money from the same donors, right? From the same high-income countries, and we're all sort of selling this big impact and lives saved with these donors, and we need to then report on that. So then there's a lot of rhetoric about let's move away from diseases and really focus jointly on health system strengthening. That's very threatening to many of these disease funds because it questions the raison d'être, right? I mean, so the bank is not, the bank is more, it's more general, right? We don't do only health. We do all of the sectors, and we don't focus on diseases. So, I mean, that's personally what I've enjoyed in this job, is that we don't do that. We don't have a disease-specific focus, and we focus on health system strengthening investments. But I do think this disease fragmentalization is a big issue, and I cannot see how to reduce it without it being pushed from the donor side. Me in countries like the Netherlands and like others that are investing, I think they need to go and really enforce that when they pledge support to these institutions, because in the end, an institution behaves according to the incentives it's given, and it's the reality.
It's not only an economic issue, of course. If you go to an HIV clinic in many countries, they are treating HIV, but you're not being in low and middle income countries, you're not treated for other diseases like diabetes or high blood pressure, etc., etc.
Yeah, but you have, I mean, I don't want to speak for other donors, but a lot of the resources, development assistance is off budget, right? It's not going through ministries of finance. It's basically by countries procuring, setting up projects, procuring. So then you have little trucks that provide certain treatments or vaccines that can't be used by the other project. That's really crazy. And I think the only way forward is to pool resources through a government budget within the Ministry of Health or Finance and let them do the procurement, and stop doing this.
Very clear. Okay, no, I agree. There was another question.
Thank you very much. I feel myself caught in the intersection of all four of these wonderful presentations, because working on performance-based finance for the last years, what I found is that it's very effective if you work locally, which means that you involve the local people, the clients and the health workers. You get a system that works. Then PBF becomes more interesting and bigger, and then you get protocols and things that you all of a sudden you're covered by a kind of standard approach, which does not work so well. But then at the same time, you want to find the researchers locally who can do the job of finding it. So what you do is you do capacity building, and then all of a sudden I find myself being involved in careerism of the local researchers. And then you try to, well, you know, I'm just trying to say is that all the things that were brought this afternoon forward in some way exclude each other. And that's my biggest question mark. I mean, how do we find a way forward that is non-colonial, that is, I mean, we're given a lot of money from the Belgian government to do capacity building, and then we do capacity building, but then they say, no, it's research, because we are working for one of those colonial institutes that's called the Tropical Institute, etc. And then you get yourself in a struggle with the donor, which is a government, and the donor says, I don't want you to anyway, I'll keep it short.
Yes.